All right, so far on our trek through the dirty, restrictive back alleys of industrialized London, we've met most of the interstitial lung diseases, which on pulmonary function testing cause a restrictive lung disease picture. In this scene, we're going to add a couple more to the list: sarcoidosis and berylliosis. And it's the same old chronic inflammation leads to fibrosis of the interstitium, leads to lung restriction. But this time we have granulomas. And we've left the 1800s behind, by the way, because the first few games of football played in Sheffield, London in the mid-19th century look nothing like the soccer we know today. So let's head out onto the streets and kick around a few granulomas, shall we? Soccer. The beautiful game of passing and dribbling and more passing. Was that more dribbling, I see? Okay, in all seriousness, I love soccer. And the best part about it is that it can be played literally anywhere, including out on the street. At Sketchy, when we say soccer, you say sarcoidosis. Though we don't really know what causes it, we do know that it involves a bunch of non-caseating granulomas popping up in multiple organs throughout the body. However, it's the pulmonary component of sarcoidosis, caused by granulomas in the lungs and hilar lymph nodes, that cause the initial clinical manifestations of disease in many patients. On the inside of a granuloma is a collection of macrophages, or in the world of Sketchy, a collection of macro cages, represented here at the sideline by the cages of soccer balls. Think back to those Sketchy micro videos for a second. Mycobacterium tuberculosis also causes granulomas in the lung, but those ones have that gross, cheese-like necrosis in the center. So broken down necrotic macrophages were represented by broken down cages. These cages are not broken. That means non-caseating. Sarcoidosis is actually a pretty common disorder, accounting for about 25% of chronic interstitial lung disease cases. In the US, sarcoidosis is seen more commonly in African Americans, 10 times more frequently than in the white population, in fact. The disease is also more common in women than men, and incidence peaks between 20 to 39 years old. So whenever you think of sarcoidosis, think of a young, female, African-American soccer player. Interestingly, sarcoidosis is actually more often found in non-smokers. Weird, right? Look, I know this is street soccer and all, and the first rule of street soccer is no rules, but please refrain from smoking on the field. All right, before the match starts, let's quickly go over the pathogenesis of sarcoidosis. Simply put, this is a disorder in immune regulation. Some unknown environmental antigen, mold, pollen, pesticides, a virus? Something causes your CD4 helper T cells to go crazy and launch a cell-mediated immune response. Some people may be genetically predisposed to trigger this response, and research suggests that mutations in the MHC genes or certain HLA genotypes may be to blame. Either way, all these activated helper T cells get a little overexcited, release all kinds of cytokines, and activate macrophages. In multiple focal areas, these inflammatory cells and cytokines form little mosh pits of inflammation, with macrophages at the center, and you're left with non-caseating granulomas. At Sketchy, CD4 helper T cells are represented by helper T cell squires, because CD4 cells are kind of the support staff for the real fighters of the immune system. And in this scene, squires are the mascot of the local street soccer team. Look, it was either that or the goal-seeking missiles, okay? And squires just chants better, you know? Well, underneath the sign, we've got a kid shooting that last bit of backwash from his water bottle into his mouth. You see that? That's our symbol for bronchoalveolar lavage, or BAL, a technique that involves squirting some fluid into a small part of the patient's lung, and then collecting the fluid for examination. Well, if you do that, you can actually see the overabundance of CD4 cells that occurs in the setting of sarcoidosis. It's not a very sensitive or specific test, but the CD4 to CD8 ratio will probably be greater than 2:1. That means lots of CD4 helper T cells instead of CD8 killer T cells. Here's another clue. Sarcoidosis patients will often exhibit anergy, or no immune response, to common skin antigens such as Candida or a PPD test. Imagine all of your patient's helper T cells stuck in those granulomas. Then they can't do their jobs in the periphery, and the body won't be able to respond to stimuli that usually elicit a type 4 delayed type hypersensitivity reaction. CD4 cells are crucial for mounting that response, and a PPD test is a perfect example of that. This is depicted here by this energetic-looking benchwarmer who's fast asleep and won't even react to this antigenic stimulus of a feather to the nose. Come on, it's like the classic way to wake someone up. Works every time. Helper T cell dysregulation in patients with sarcoidosis can also cause a polyclonal hypergammaglobulinemia. This means a lot of different helper T cells activating a lot of different B cells, which then produce a lot of different antibodies. Kind of like this myriad of antibody-shaped keys dangling from the ball cages. So now that you know a bit about the pathogenesis, or at least appreciate how mysterious the pathogenesis is, let's talk about what to expect on histology. Like I've said before, the diagnostic histopathologic feature of sarcoidosis is the non-caseating granuloma. As we'll illustrate in our inflammation unit, granulomas are formed by a discrete, compact collection of activated epithelioid macrophages surrounded by an outer zone of those CD4 helper T cells. One of the cell types I want to focus on in particular is the multinucleated giant cell, which can be seen within the granulomas. Giant cells form through fusion of multiple activated macrophages, and inside that ball of cytoplasm, multiple nuclei can be seen floating around. It looks kind of like the multiple purple panels on each soccer ball, actually. These cells are not specific to the granulomas of sarcoidosis, but definitely a buzzword that the question writer will throw in there to let you know that something granulomatous is going on. There are two other high-yield microscopic features that are sometimes found in granulomas. The first is an asteroid body, which is a stellate inclusion enclosed within giant cells. So look closely, and you'll see that some of the panels on these multinuclear soccer balls are now star-shaped. The second characteristic feature is called a Schaumann body, which is a laminated concretion of calcium and proteins that looks like a big purple spot inside the granuloma. Think of this Schaumann showman, showboating like he always does after scoring a goal. Okay, we get it, Len Shackleton. You can put your shirt back on. As he places that purple cleat on the soccer ball, I want you to imagine a big purple spot in the granuloma. We've also represented some of those laminated calcifications there. Just some spillage from his victory milk. Milk, the drink of winners. Remember, giant cells, asteroid bodies, and Schaumann bodies are not required for the diagnosis of sarcoidosis. They can be found in any disease that contains granulomas. Okay, so that's what sarcoidosis looks like on a micro level. How about we relax our eyes a bit and look at the bigger picture? First, the lungs. 90% of sarcoidosis patients get lung involvement at some point during the disease. So imagine the left and right halves of the soccer field as left and right lung fields. The granulomas can be located in the interstitium, which is why clumps of balls are scattered throughout the field. But it's also important to remember that the granulomas can also be found in the hilar and paratracheal lymph nodes, which is why we've added some aggregates of soccer balls in the center circle near the midline. Early on in the progression of the disease, you see the classic bilateral hilar lymphadenopathy. Hilar and paratracheal lymphadenopathy is a crucial identifying factor of the disease, since 75 to 90% of patients will have this presentation. Yep, chest X-ray is essential for diagnosis. Look for the enlarged hilar and mediastinal lymph nodes to show up as an obvious hilar fullness on the radiograph. They're sometimes even called potato nodes. You see that devoted fan sitting in the middle of that pulmonary tree up there? Right on the mediastinum. Let those soccer balls remind you of those enlarged hilar nodes. At Sketchy, whenever we want to emphasize important X-ray findings specifically, we'll always include a recurring X-ray pirate flag. If you take a biopsy of one of those nodes, by the way, you're sure to find some of those non-caseating granulomas we've been talking about. Later in the course of the disease, the granulomas can actually be replaced by diffuse interstitial fibrosis, which is why we've also included a recurring pulmonary fibrosis tree. Remember, we're in the restrictive lung diseases chapter here, and the X-ray findings can be pretty typical of your average interstitial lung disease. Scan the lung fields on that radiograph, and you're sure to find some reticulonodular densities or ground glass opacifications, just like we described in our interstitial lung disease overview video. But definitely keep an eye out for those nodes. I'm telling you, it's a test writer's favorite. Bilateral hilar nodes in a young African American female patient. Count on it. So, how will all this pulmonary involvement present in your office? Well, sometimes the disease is asymptomatic and that bilateral hilar adenopathy is discovered incidentally on chest x-ray. Most symptomatic cases present with a gradual onset of dyspnea on exertion and a chronic dry cough, typical of the chronic interstitial lung diseases. You know, it's not uncommon for a soccer player to run about 7 miles during a full match. Yeah, I'm getting dyspneic just thinking about it. Patients with sarcoidosis will often present with constitutional symptoms as well, as depicted by our goalie here. I mean, it is a pretty stressful position, and all that chronic anxiety, now presenting as fever, malaise, weight loss, and anorexia. Notice how that oversized goalie jersey clings to his skinny arms. Pretty non-specific stuff, huh? That's why sarcoidosis is sometimes considered a diagnosis of exclusion. If you're only considering the lungs, for example, there's no obvious skin lesions, eye problems, etc., which we'll cover in a minute, then you should rule out other granulomatous lung diseases first. Some examples include tuberculosis, fungal infection, and berylliosis. However, while the lungs are clearly the most important component of sarcoidosis, there are some pretty characteristic extrapulmonary symptoms to watch out for. Skin lesions, for example, are present in about a quarter of cases, the hallmark lesion being erythema nodosum. It consists of raised, red, tender nodules on the anterior aspect of the legs. And, you know, I said no rules in street soccer, but that doesn't mean absolutely no rules. We're not savages. So let's don those shin guards, people. It's the perfect way to depict the red, raised spots of erythema nodosum, right on the anterior aspect of the legs. Okay, I know. Ari and Robin over here just loves to flop and grab that shin guard. Just perfect injury faking technique. But he's not faking it this time, my friends. The lesions of erythema nodosum can be painful. That's inflammation of subcutaneous fat happening under there. Interestingly enough, they usually do not contain granulomas. Notice, too, that he has some bits of gravel embedded in his road rash. Sarcoidosis can also present with subcutaneous nodules, but these ones are painless. He's focused solely on that shin guard pain. By the way, if you were to take a biopsy of one of these nodules, you'd actually see an abundance of those granulomas in there. Another skin manifestation of sarcoidosis is called lupus pernio, which is a violaceous rash on the nose and cheeks, represented here by this unnecessary but still kinda cool looking purple athletic face paint. Now, it's only called lupus pernio because it looks similar to the face rash seen in lupus, but it's, of course, pathologically quite different. It's not even similar to pernio. It's just an all-around terrible name. Up to 1/2 of sarcoidosis patients will experience issues with their eyes or lacrimal glands. Take this kid, for instance, with his blurry red-rimmed protective goggles. He represents the symptoms of anterior uveitis seen in sarcoidosis, which can cause blurry vision and redness where the cornea meets the sclera. Iritis, specifically, can even lead to glaucoma. The disease can also manifest in the posterior uveal tract with resultant choroiditis, and also extend to the retina and optic nerve. Hence those broken retinal-looking streetlights with the severed optic nerve wires. Unfortunately, when the retina and optic nerve are involved, that means vision loss. Also, you see that empty water bottle he's squeezing, trying to get out the last drop? This depicts the lacrimal and salivary gland involvement, leading to keratoconjunctivitis, sicca or dry eye, as well as xerostomia or dry mouth. Just pretty dry overall, really. This is a granulomatous disease, remember, and these granulomas are found throughout the body, in numerous organs. And they go straight for that liver. So we've included our recurring hepatomegaly liver spot on the team mascot, a medieval squire's cow. Sarcoidosis is the most common non-infectious cause of granulomatous hepatitis. In this case, you'll see microscopic, non-caseating granulomatous lesions within the portal triads. However, only about 1/3 of these patients will demonstrate hepatomegaly or abnormal liver function. And the granulomas just keep coming. How about cardiac sarcoidosis? Although usually clinically silent, it can manifest as various types of conduction disease, arrhythmias, and myocardial damage. Endocardial thickening and non-compliant ventricular walls can sometimes cause a restrictive cardiomyopathy, represented here by our helpless goalie, who does look a little restricted in that net back there. Check out our cardiomyopathy Scottish game sketch for all the clinical manifestations of restrictive cardiomyopathy. All right, here's where the systemic syndromes really get interesting. A classic clinical manifestation of sarcoidosis, sure to find its way onto a test question, is hypercalcemia. Just think of our squire here, raising up that fresh cold glass of milk. It's the drink of winners, and it tastes like victory. But where does all that calcium come from? Well, it has to do with all those granulomas that are forming. Within the granulomas, activated macrophages produce extra amounts of 1-alpha hydroxylase. Recall from our sketchy farm vitamin D video that this enzyme is responsible for adding that last hydroxyl group to form 1,25-dihydroxyvitamin D, the active form. Remember, too, that natural sunlight is what initially activates vitamin D in the skin. So, to represent hypervitaminosis D, we've added some super bright streetlights, as bright as that vitamin D-inducing sun. Notice that they're being powered by that 1-alpha box, to remind you of extra 1-alpha hydroxylase activity specifically. And as you can imagine, more active vitamin D means increased calcium absorption in the gut, and hypercalcemia. Hypercalcemia, in turn, can even lead to hypercalciuria. See all that milk dripping out of the cow? You'll spot a few stones mixed in there, because increased calcium in the urine means an increased chance of calcium kidney stones. No, thank you. Okay, so many organs involved. But keep in mind that it's those pulmonary symptoms that are most common, and likely what will be emphasized on the exam. And since we're on the topic of lab values, let's talk about just one more interesting lab finding.
What? Oh, come on. Get your eyes checked, ref. What, do you have posterior choroiditis progressing to optic nerve involvement and here it is, okay. Yep, the ref's pulling out his, ACE card? Just a warning, or?
That raised ACE represents a nonspecific but fairly common finding in sarcoidosis, and that's increased levels of angiotensin converting enzyme, or ACE. This is yet another enzyme produced by the granulomas themselves. This serologic marker can be found in other diseases as well, and has no specific clinical utility, but you'll see it in a question stem or two on the exam, so keep an eye out for it. All right, and finally, treatment. Although the disease course is unpredictable with periods of activity interspersed with remissions, most patients have spontaneous and full remission within 3 years of diagnosis and do not require any treatment. For symptomatic patients with progressive disease, a course of glucocorticoids can be given to initiate remission. Remember that chronic glucocorticoid use can cause a Cushingoid picture with moon phases, which is why our recurring symbol for glucocorticoid therapy is that eerie moon phase. This time, drawn on a few of the practice balls out on the field. That's it for sarcoidosis. And before we head over to the next chapter, I just want to briefly mention one more chronic interstitial lung disease that can present with both fibrosis and granulomas: berylliosis. Berylliosis is, in fact, a pneumoconiosis because it deals with inhalation of small dust particles, specifically beryllium dust particles that can be found in the nuclear and aerospace industries. Hence the aircraft hangar in the back. Just your average back alley aerospace operation going on. Berylliosis shares many clinical and histopathological features with pulmonary sarcoidosis, including the presence of non-caseating granulomas, which are represented, again, by a pile of cages along with an errant multinucleated soccer ball. Also, think back to the guy over there in the lung tree, because chest X-ray findings can be very similar to those found in sarcoidosis, including hilar adenopathy and reticulonodular infiltrates. The infiltrates may be more prominent in the upper lobes, which is why we've included these aerospace particles falling on the upper lobes of this fibrotic lung tree. Yep, our recurring fibrotic lung tree, which again means the disease can progress to a diffuse interstitial fibrosis. Similar to what we see in sarcoidosis, the clinical picture involves the insidious onset of dyspnea, fever, and weight loss. More advanced symptoms include cor pulmonale, much like many of the other interstitial lung diseases. Keep in mind that the latency between exposure and onset of symptoms can range anywhere from 3 months to 30 years. Well, that concludes our chapter on the interstitial lung diseases. Just to quickly recap, Sarcoidosis is a disease characterized by non-caseating granulomas in various tissues and organs throughout the body. Some unknown antigen causes CD4 helper T cells to go crazy, release a bunch of cytokines, and proliferate. You'll even see them on bronchoalveolar lavage, and they'll be so distracted that they'll forget to respond to normal skin antigens, like a PPD test. The disease manifests most prominently in the lungs. So watch out for a young African American female patient presenting with dyspnea and constitutional symptoms including fever and weight loss. Get a chest X-ray and look for those enlarged hilar lymph nodes. Get a biopsy and look for some non-caseating granulomas. The eyes can be involved, as shown by our anterior uveitis goggles player as well as the broken retina lights. The skin can be involved, as shown by our injured erythema nodosum shin guard-wearing goalie, covered in nodular gravel and purple lupus-like face paint. The liver can be involved. Special thanks to that mascot for that lovely liver spot. As well as the heart, shown by our goalie in the restrictive net. On labs, you might see a lot of IgG, a lot of ACE, and a lot of calcium from overproduction of vitamin D. Berylliosis can present in a very similar fashion, so look out for a history of working in the aerospace industry to help guide the diagnosis. I'd also like to thank our sponsor, Milk Vitamin D Energy Drinks. Milk, why be awake when you can be awaker?